we can also then add those questions as well. So it's really going to be a free flow. We want everybody to engage and really take some of the thoughts and learnings that we've had over the last few days, and let's bring those all together. Then following the panel discussions, hopefully we'll have a moment just to see if there are any live questions that people would like to pose. And then we're going to hand over to Tracey, who's going to run through the Bettercare book and how best to use it, because I think it's so important to understand the whole Bettercare process, because it is a different way of learning. It's interactive, it's a study group, and as you all know, we asked you the question on registration if you'd be willing to actually be open to participating and facilitating a study group yourself. So we will ask those questions again, and if anybody then decides that they'd like to after having said no, please just send us an email and we'd love you to participate. So without further ado, Sue, I'm going to hand over to you to introduce the panel, and then we can start with the questions. And just remember, we'd love you to participate, send us some comments, and let's keep this as interactive as possible. Thanks so much, Sue.
Thank you, Melissa, and welcome everybody again. On behalf of PATCH South Africa, we are just so thrilled to have such a great response from around the country. I am going to introduce the panel members. I'm not going to go into too much detail. I'm just doing it from my head because I have the absolute privilege of knowing all these people personally and knowing them well. The members of the panel that you already know are Melissa and Tracey. And those of you who joined us on Tuesday, you did meet Dr. Julia Ambler. But just a little bit more about Julia, because we didn't spend too much time introducing her. Julia is the co-founder of Umduduzi Hospice Care for Children, along with Tracey Brand. She's also the medical director of Umduduzi. And Julia's roots in children's palliative care go way back to one of the very first children's hospice, in fact, which was Helen House in Oxford. So Julia actually did her training, her training under the author of Children's Palliative Care for Children, which is Justin Amory. So Julia has a very, very rich and deep roots in children's palliative care, and she provides palliative care, amazing medical palliative care to the children of KZN. Then the second person I'd like to introduce happens to be very close to me, which is my sister, and that's Joan Marston. And Joan is the reason I am in children's palliative care today. She hooked me in 2008. And Joan is well known around the world, not just in South Africa. Joan is a global ambassador for children's palliative care. She's presently on a WHO group. She's co-chair of PalChase, which is an organization that provides palliative care to people in emergency situations. And she is a global ambassador for the ICPCN, an organization which she helped found and which she was the chairperson for many years, the CEO of for many years. So that's Joan. She also founded Sunflower Children's Hospital Hospice in Bloemfontein, and that was in the 90s. So Joan also has an extremely rich and deep history in children's palliative care. Tracey Brand is co-founder of Umduduzi. Tracey Brand is a medical social worker with a master's degree from UKZN. She's our go-to person for communication, for anything to do with social work in the pediatric palliative care field. And then finally is Dr. Michelle Meiring, and I haven't seen her on the call. Is Michelle on the call? No, not yet. Michelle is an extremely...
I am here.
You here?
Yes, I'm here.
Oh, wonderful. So Michelle is the chair of PATCH SA. She has been really the person that has continued to push for pediatric palliative care in South Africa through a national network. And we started off with a different name, but we became known as PATCH SA. I think Michelle has been the chair from the beginning. She is a pediatrician who specializes in pediatric palliative care. She's the founder and the director of Peds Pal in Cape Town. He has just finished an enormous task helping Dr. Richard Hain and a couple of other global pediatric palliative care specialists to edit the newly released Oxford textbook on palliative care for children. So that is our esteemed panel, and I'd just like to really welcome each and every one of you. I have spoken about Tracey and Melissa. We have said that they too will be part of the panel. So that's the welcoming to everybody. I hope you're going to add your questions, but we have received some amazing questions from our panel, from our participants, and I'm going to be the one that is going to be asking these questions and fielding the ones that come in while we talk. The first question I have for Julia, and it's quite a controversial question, and I think it's one that a lot of people would like to know. And that question is, when is it safe to give morphine to children? Is it safe to give morphine to children who are in pain? And doesn't giving morphine increase the likelihood of the child dying? So Julia, Dr. Ambler, if you would like to field that question for us, please.
Thanks, Sue. It's one of my favorite questions because everyone knows that morphine is my favorite drug. I don't take it myself, but what we do know, it is one of the most versatile and effective pain management tools that we have available. It's cheap and it's available in all our South African hospitals. So we're very lucky in South Africa to have such an incredible option in terms of pain management. The doses that we use in children are really safe. It's all the reading I've done over the years, and in 17 years of working in pediatric palliative care and using morphine almost every day, I've had 2 incidences where children overdosed accidentally on morphine, and both times it was a doctor error in the prescription. Neither child died. Both of them were able to get to hospital in time and receive medication, the naloxone, to reverse it. But at no point did either child lose consciousness or even come close to dying. So what I've really realized, it's very hard to kill someone with morphine. You actually have to drink so much for it to have that kind of effect. So where it is really useful is in all children that have got serious ongoing pain, where your lower level drugs haven't worked or aren't sufficient. So I would strongly encourage people to get familiar with their use, to feel quite safe in using it. If you follow the guidelines around how to dose, when to dose for the right age group, for the right indication, you cannot go wrong.
Fantastic. Thanks so much, Tracey. Does anybody have any questions following Tracey's response? Please just unmute yourself or put your hand
Julia.
up.
It's okay. Nancy's Tracey.
Okay, if there's no questions, thank you, Julia, for that answer. I'm sure if people think of them, please feel free to put them into the chat box. The next question is also a medical question, and we have it for Dr. Michelle Meiring. And this is also a very controversial question that a lot of people have great difficulty with. So, Michelle, could you answer this question that we had? Why do pediatric palliative care doctors withdraw feeding when a child is nearing the end of their life? Surely this is a cruel practice, and it is likely to speed up the dying process. If you could answer that question.
Thanks, Sue. So yes, it is a very, very controversial and difficult thing to do. And I think the reason it is difficult is because we regard feeds as a basic right, something that one has to do. And I think also when it comes to nurturing and things that parents want to do, withdrawing feeds seems to be absolutely the most painful thing that anybody could consider. But one also needs to look at fluids and feeds as something that can actually cause suffering at the end of life. I think a lot of doctors have become more comfortable with doing things like withdrawing ventilation and TPN and antibiotics in an actively dying child because those are seen as medical interventions, whereas I think feeds and fluids are seen as more basic provisions, but they really should be seen in the same light. And actually the reason why we withdraw fluids and feeds at the end of life is actually when the body is shutting down, the body can't actually absorb a lot of these nutrients. And many of you may have actually witnessed babies that are incredibly uncomfortable as people try and pump food into a bowel or an intestine that is actually slowing down. You see abdominal distension, you see vomiting, you see pain and discomfort. And actually it's part of the natural process. I often like to talk about it like this. If you think of the olden days when we didn't have nasogastric tubes and drips and those kind of things, people just couldn't be fed at the end of life. And it was actually part and parcel of dying that you stopped feeding somebody. And actually, I think a lot of the processes that exist in our bodies were created by God, or whoever you might believe in, to actually assist with transition between life and death. And there are a lot of useful things that actually happen when one starts to withdraw feeds and fluids. So one of the very useful things that happens, and those of you who have fasted for religious reasons would know this, when you start decreasing your calorie intake, your metabolism changes and you become ketotic. And those ketones that are released have a number of very important functions. Number one, they actually serve as assisting with pain control because it helps with the release of endorphins. And ketones also make suppress your appetite. So I think people don't have to worry that the baby is hungry because ketones are actually suppressing appetite, which is why the longer you fast, the less hungry you feel. So, you know, there are actually a lot of advantages to dying dry as well. You know, you're not going to aspirate because your stomach is not full. You're also not going to have excessive secretions that is going to cause you to feel breathless. And also, you know, if you've got a lot of swelling in the body in terms of in the brain and in the tissues, stopping feeds actually helps to decrease that swelling. So there are actually a lot of advantages to not feeding at the end of life that we actually negate by trying to continue to feed. And it also helps to support the normal and natural dying process by stopping feeds. It's not normal to feed dying people. It just really isn't.
Thank you, Michelle. I think that really covered, it was really good, comprehensive answer. If anybody else has any other questions, though, please do feel free to put them in the chat. Just to go back to Julia, if you don't mind, before we go to Tracy. Julia, I see someone has asked, oh, you did answer. Someone asked if it's safe to give morphine to very small babies, to newborn babies. Julia, do you just want to say?
So yes, it is safe, but obviously we need to understand the pharmacokinetics are different in a smaller baby. So we use much lower doses as a starting point, and we also increase the dose interval. But if we're following a guideline and we're being very careful according to the weight of the child and the age of the child, again, it is safe.
Thank you, Julia. That's great. And then the question that has also been posed in the chat and is actually very similar to the question I'm about to ask Tracy, and that is, Tracey Brand, how do you break difficult news to parents about a child's diagnosis? And how do you approach the subject of death with a child who is terminally ill? And the question has been posed about siblings. Do you provide individual counseling to siblings? So Tracy, if you could cover all of those, that would be great.
Thanks, Sue. I'm going to do my best in the time allocated. I'm going to start with the breaking bad news. And obviously it's something that's incredibly difficult to do. And I think no matter how often you do it, you still get a little bit of a flutter in your tummy as you walk in the door, because you never know how a family is going to respond. And we look at, and I'm sure most of you have heard of the Sparks model in terms of your setting, etc. And if you don't know, give me an email afterwards and we'll go through it. But when we've got to make sure we're in a safe place for both the family and the patient. And this shouldn't be done at the bedside if possible. It should definitely not be done in the corridor. And it should be done in a place where you're not going to get interrupted. And one of the things that we do a lot with the families that we work with is we ask them to tell us their story. What has led them to being where they are now? And they go through the whole history of how many clinic appointments they had, and then they ended up at base hospital, and then. And they're slowly working out themselves how long they've been in the healthcare system. And then we come into say to them, well, look, there's more information we need to give you. And we use an acronym called WPC, and that's warn, pause, and chunks. And what that means is you start very generally. So for example, if you're working with a family whose child has been diagnosed with leukemia, you would start with as you know, the doctors were worried about your child's bloods. They were worried that the counts were too low. So we did tests. Do you remember us doing those tests? And they say yes or no, and they might fill in information for you. And then you say, well, look, we've got those test results back, and unfortunately, we have some bad news. So that's your warning. You're giving a warning shot, and you pause because sometimes you physically see a person do this. They physically like brace themselves for the news that you're about to give them. And then you don't go straight and, well, your child has leukemia, because then you're going to lose them straight away. You start with saying, well, we did the blood results and we are very concerned that there is something wrong with your child's blood. And unfortunately, upon more testing, we've discovered that it's a blood cancer. And then you pause again. And then you go on to explain what kind of blood cancer, what that means, and wait until the family are ready to hear more information. We give it in chunks because often the people get overwhelmed. The minute you say cancer, screensaver comes up and there's not much information you're going to get to them. And we do this process until one of three things happen. There's nothing left to tell the family. The family themselves are too overwrought to hear what treatment options are available, what the next step is, or you yourself are too emotional because it's been such an emotional time. And what we then need to do is say, look, there is more we need to talk about. Now's not the right time. I can see you very upset. I'm going to give you a few moments and I'll come back when you're ready. By all means, go back, because often we get distracted and our shift ends and then we forget to go back. So I think one of the imperative things is if you say you're coming back, make sure you're coming back. If you're not on duty tomorrow, let the family know that you're not going to be on duty tomorrow, but that your colleague knows exactly what you've spoken about, and that if you have any questions, they will be able to give you all of that information. And when it comes to working with children, I think the most important thing is to fully understand what a child is asking you. I think we often put on our, well, we don't put them on, we have them, our adult ears, and we get frustrated because children are taking too long to explain what they're wanting to do and what they're wanting to know. And so we start putting the words in their mouths, and we then give them the wrong information, and then they feel like we're not a person who can trust them. So the important thing is to answer a question with a question. So if a child says to you, am I going to die? They might not mean today. They might be referring to in 20 years' time. So the question would then be, well, what do you mean by that? And slowly get them to unpack exactly what they're wanting to know. And then in a similar process that you would use with the family, is slowly explain in child-friendly terms, given the child's age and cognitive ability, about what's going on. And, you know, for example, somebody living with HIV, from little, you can disclose to them that they're living with HIV. You just have to say that they've got a bug in their blood and the bug is making them sick. Everybody knows what a bug is, and that this is the medicine that you're going to take to help you with the bug. And then as they get older, you can say the virus's name and the antiretrovirals names. So I think the important thing with kids is just to always make sure you understand and meet them where they are. I think one of the things that we have found the most, and I'm sure my colleagues will agree, is that many of the children themselves know long before we do that they're going to die. And they tell us, you know, you leave on a Friday and they go, thank you for everything, you know, goodbye. And you say, oh, you're going home? No, not really. You know, I won't be here on Monday. And, you know, it's really interesting when you have those conversations with children, because then you can actually, you know, go to them and find out what they believe and get them prepared if they want to leave a legacy, if they want to donate their toys to family or friends. And so I think the biggest thing with our families and with our children is we've got to be honest. Children will find you out if you lie. So be honest with them. And if you don't know, say that. Say, I don't know, because that's not a bad thing. And the similar thing with siblings is to have the same conversation and to help them address that magical thinking that because they wish their brother dead, they now have a terminal illness. And I think that the whole process, while it is very difficult, it doesn't have to take hours. You just need to be there in that moment and give the news in the most gentle and loving manner that you can without using big words like marmalade, because nobody gets those, only we do. And to really, when we're working with our kids, find out what they want to know, exactly what they want to know, before we take them on a path that's going to terrify them. And if there's much more to say, so you can drop me emails if you need more information. And
thank you so much. There was a question about siblings. I think you must have read that, about the magical thinking that they might have caused it. So thank you. And I'd also like to encourage everybody to go to our Patch Academy, because in fact, Tracy, Melissa and I, Tracy Brand and Tracy Rawlins, Melissa and I, we're actually the ones that put together the training on communication. So if you want a really good online learning experience, please head over to Patch Academy and to do the course on communication, because it goes into all the things that Tracy spoke about. Michelle, there's just one I see that came in for you. I don't know if you saw it, if you'd like to address it. It's, what are your views on discharging a dying patient home on an NGT instead of oral feeds?
Yeah, thanks, Sue. Quite a common clinical scenario. And a lot of the decisions around feeding in patients with advanced illness and dying patients really depends on timing and how close they are to the end. And obviously that's often unpredictable. And obviously, you know, if a patient is not imminently dying, but probably going to be dying soon, but they're still going to be hungry, you know, it's really not nice to feel hunger and not be able to receive feeds. And also in those instances, if you can actually get the child home, especially if the family wants to look after the child at home, putting in a nasogastric tube is obviously a very good solution. Obviously, on the other hand, we don't want to be overly placing tubes in children and protracting their dying. And that's where the skill comes in terms of being able to predict how close we are to the end. A very useful concept that I always practically use and also teach is something called feeding for comfort. So, you know, you let the child guide the process, and if the child appears hungry, you feed the child, but you don't feed according to a clock, you know. So if this is a dying child and maybe it's a dying baby, you're not going to feed 3 hourly like you would a normal neonate. You're going to feed that child when the child actually appears hungry. And then as the dying process actually proceeds and the child is less hungry and the child demands feeds less, then obviously the frequency that you're feeding that child is going to decrease. And then you actually much more naturally move between full feeds, comfort feeding, to not feeding at all. Obviously, I know a lot of hospitals have different policies about sending kids home on nasogastric tubes. I know a lot of people across the country are still very nervous about it. So, you know, usually when we send children home on nasogastric tubes, we make sure that we can mobilize an existing resource in the community. We'll often write letters and say this child is being sent home to the local clinic, and tell the clinic, if the tube comes out, would you please assist us in reinserting, so that the families have got a port of call if that tube comes out. Obviously, with older kids, there's no rush to get that tube reinserted in the middle of the night, and we also make sure that we spend a lot of time counseling families on how to manage a tube at home at night. But it really does actually help to get kids home where the families have the capacity to manage that at home.
Thank you so much, Michelle. That's great. I see lots more questions coming in. The next question that I'd really like to put to Tracy Rawlins, and Tracy is so well read and so knowledgeable about grief and bereavement, and so she is certainly the best person to answer this one. And the question for you, Tracy, is how can healthcare professionals provide support to a grieving family both before and after the death of the child?
Thank you. Yes, I think it's such a big question and a vital one too, but it's really difficult to answer in this short period of time. Honestly, there's so much to cover, but I think it's important for us to understand the terminology that we use in palliative care, the words loss, grief, bereavement, and mourning, because when we grieve, we only grieve because we've had a loss. And to understand that loss can be primary and it can be a secondary loss. So primary loss would be when the parent or child is given the diagnosis of the illness or condition. When the treatment has to be stopped, again, that will be a loss because they know that is now stopping and what is going to happen next. There's another loss. And then again, when the child does die, whenever that's going to be, that would be another primary loss that's happening. And then we look at the secondary losses that would go with that. So you're going to be grieving all the primary losses. The secondary losses would be for the parents, the future of that child, for the child themselves, their own future. And we could go into so much detail about all those different secondary losses. So when we look at grief, grief is about loss. Mourning is the outward expression of how we show our grief. Grief is the emotional side, the feelings, the behaviors, and the thoughts that we have when we are given bad news, when we have that loss. Then bereavement is that period of time from when we start experiencing loss and grief. So it's very important to be able to put those concepts into place. And then there's another big area that we talk about in palliative care, and that's anticipatory grief. And that begins from the time of diagnosis. So that's going to be what losses are we going to incur through this illness journey. Every pathway, every turn, there's going to be some loss over that journey of the child. And it's important to understand that it's not just the parents who are going to grieve, the child themselves who has been diagnosed is going to have anticipatory grief. And I've just been doing some sessions with matric students at a local school with COVID and grief and loss. And the losses they're experiencing, the anticipatory losses that come out are great. It's about their sport, their matric dance. So we've got to look at all children grieve. It doesn't matter where they are in their childhood, the adolescence, they grieve. And just being aware that they start grieving from diagnosis. And then we mustn't forget about the siblings that are included here. We often talk about parents and the child who's ill, but there's a family that go along with that, and they are often the forgotten ones in the family, are the siblings. So they will be grieving, but sometimes they're grieving very quietly on the side because they're not being included in the conversations, in the illness journey. So please remember to include them in that process of talking to them, breaking the bad news, as Tracey said. And then we've got to know that even babies can feel some form of loss. They experience it through their families, toddlers, young children, but everybody grieves. We grieve differently. And I think it's also very important for anyone working with children to go and learn the different ways that children grieve, learn about their age groups, their cognitive abilities. How do they understand grief? Because you've got to support them where they're at. You can't do the same for a 2-year-old that you would do for a 5-year-old and how you would support them. So it's important to remember that the grieving process starts from the minute of diagnosis. And it's also important to tell the truth to the family, to the child who's suffering and has got the illness, to the children, the siblings that are going. The truth needs to be told to them. And as Tracey explained, how we told them the truth. And for siblings, when they're grieving, they need that extra support. They need to have their routines as normal as possible. They need to be going back to school. They're going to be, maybe their behaviors are going to be different. It's good to involve the teachers, the schools as part of this journey with the child and the siblings as well. So they know what's going, so they can give that extra comfort and support. Extended family also grieve. So it's important to be able to support them as well. And then support needs to start before the child dies. So how do we support that child in a hospital, in a tertiary facility? And really it's about teamwork. Everybody needs to be on the same page. We need to be speaking the same language. The family need to be hearing that same message passing through. And it's about planning. So the minute they're diagnosed, we start planning, and we talk about advanced care plans, but plan. I know you may laugh at what I'm saying, but it involves planning, and it involves the whole team. And part of that team is the parents and the child. So you can make that grieving process easier for them, because if they know what's happening, we all fear the unknown. And if we're not telling them what's happening, we're not including them in the decision making, that grief can become complicated when they don't know. And I know yesterday, listening to Melissa's story, this is a lot came out about that. They were grieving as a family right from that word go. They needed to be included to hear what was going on. And then decision making, let the family be involved, let the child be involved in the decision making. What do they want to happen to them through the illness journey? And all of that can allay some of that grief. And then including the siblings. And then if we're going to start talking about towards the end of life, memory making, that can help with legacy planning. Tracy spoke about legacy planning on Monday with Hannah, talking about legacy planning, putting things in place for them before. That is all part of the grieving process and how we can support. And then one thing that a parent always will remember is when we talk about the child who's just died, they will always remember how their child died and who was there to support them through that time when their child died. And telling the family when the child is dying, you're supporting them by telling them what's happening, explanations. This is what's going to happen. This is what we're going to be doing next. And even the child who may be comatose or unresponsive, hearing is the last sense to go. So even telling the child who is dying what is happening to them can ease that for the family and for the child and make that process easier. And then again, the way we can support, sorry, I know I'm talking on and on, is the environment. What sort of environment have you created for that family? Is it a safe space? Is it private? Are the curtains drawn around that family? All of this will affect how they grieve and what they remember. Also, we'd also like to say, when a child has died, do you allow time for the family to spend with their child who's died, to say goodbye, to perform any rituals, traditional rituals or religious rituals they may want to? Have they been given their time? And again, to say to professionals, don't abandon that family when the child is dying or just after it. Be there. You don't have to be supporting them in sort of dramatic ways, but just your presence can make a difference. Just a soft word, just a gentle way, just even shedding a few tears. Families are happy to see that. They feel that you're part of that process. And then if the child has died, don't make assumptions. Don't judge the way they grieve. Everybody grieves suddenly, how they react. They may become angry, the family, when a child has died, or feel guilt or start crying. Support them. Don't judge the way they're grieving. And then parents want to tell their story once a child has died. They will tell their stories over and over and over. And that's part of the grieving process. That makes them make sense of what has happened to them. So listen to their stories. They're going to tell them over. And they need to be, parents and families and siblings need to be told it's okay to grieve. It's fine. There's nothing wrong with grieving. And then as healthcare professionals, how do we support that family once they've left? Well, finding support groups in the community, getting in contact with teachers, with the school, with families who've gone through the same experience. So you're referring them outwards. And that's in that model we looked at, supporting them into the bereavement palliative care supporting into the bereavement period. That is what families need. And then they also need to, families need to, parents include the siblings in the memorial planning. So for the funeral, but also giving them choices. Do you want to attend your brother, sister's funeral? What would you like to do? Would you like to sing a song? Is there a poem you'd like to read? Those are how you can support that. It's giving everybody a voice to say what they want. And then, I know I'm running out of time, is just to say there's so many things we can say to make that family feel good, but there's so many things we do say wrong. And it's learning the language, the grief language, what families need to hear. And often it's from a lack of knowing what to say that we say the wrong things. And some of the things I'm thinking about is when someone is, I know how you feel. We don't know how they feel. He or she is in a better place. Is that so? The suffering is now over. No, for the family, the suffering is not over, maybe for their child. Well, the one we do here is luckily you still have other children. Time will heal. Oh, you'll get over it in time. Oh, you'll be able to move on in a year or two. Please think before you just make these comments. Think about that language, those phrases that are actually going to support the family. You don't know what to say, just to be present, to say, I'm so sorry, this must be so hard for you. Anyway, I think I've over my time.
That's very important, Trace, so don't we'll just talk.
I think, yeah. It's very obvious how passionate Tracy is about grief and bereavement, I think.
So please go and look at our courses or look in the Bettercare book. It's all there if you want to learn more.
Thanks.
Thank you, Trace. That was really very, very comprehensive. The next question that I have, I'm just keeping an eye on the time, so we do need to move on, is a question for Joan. Now, Joan, on top of everything else, is also very, very interested in spiritual care as part of palliative care. And, you know, for many years, Joan used to say, don't forget the children, but now she's also saying, don't forget spiritual care and spiritual pain. So the question we have for Joan is, we know that spiritual care is a part of holistic care for a child and family, but realistically, in a hospital or a busy hospital setting, how are we meant to provide spiritual care on top of everything else to children and families? How can we do that? Thanks.
Thank you, Sue. And thank you to Tracy and Tracy, because I think so much of what they've said is actually part of addressing spiritual suffering in children and in parents. And I think it starts, first of all, from understanding what is spirituality. Because if we understand it as what gives meaning and purpose to the child's life, to the family's life, and how do they connect? How do they connect to their feelings about themselves? How do they connect to others, to nature, and to something greater than they are? And of course, when we're dealing with spiritual care, we're going to be dealing with that tiny little neonate up to that big galumphing teenager who's asking lots of questions and is really angry and everything. So first of all, just a few basic steps that I think we need to lay a foundation. You can't just jump into it. First of all is understanding that spiritual care is part of palliative care. And if we don't provide spiritual care, we're actually not providing palliative care. And if we look at the WHO definition from 1998, it was included as part of palliative care. The second is understanding your own spirituality. Ask yourself, what is my purpose in life? What gives meaning to me? How do I connect? And how do I find ways of connecting, especially in this time of COVID, where we are so often so isolated? And if we also think, if we walk into a busy ward where you've got children in their separate rooms, separate cots, everything is very isolated from each other. How do we form connection in this situation? And then, of course, the basis of providing palliative care, whether it's at home or in a hospital, is doing that full assessment. So if you get into the habit of including spiritual assessment as part of your holistic assessment of the child and the family, and you put it into your care plan, and you add it into your advanced care plan, then when you review that every day, you're going to be doing it. So I think to put a few foundation things in place, and then of course it's the training. So unless we can do it, but unless everybody on the staff understands it, then there's going to be like patches of spiritual support and care for this child and this family. So if you really want to do a program of spiritual care in a busy ward, get everybody on board, get everyone thinking about their own spirituality. And this will really help them to cope as well, because one of the big questions is, how do people cope in these high pressure situations when you really are rushing off to treatments, rushing off to get pain treatment and things like that. And we know that when the child is older, we can ask questions. That makes it easier, doesn't it? We can use the FICA tool that's in the excellent online course from the Patch Academy. And we can use the belief tool. So there are tools that we can use for older children to find out what is their connection to some form of spiritual life? What gives them meaning? If you ask a teenager what gives them meaning, they might well say is being part of a group, looking like everybody else, having those Nike sneakers. And that can be really important. We had a child came into Sunflower House who'd actually tried to commit suicide because his parents couldn't afford to buy him a pair of Nike sneakers. For him, his spiritual meaning was around a pair of Nike sneakers. So we need to remember what gives them meaning and purpose is what they can tell you. So when we can ask the questions, then it's fairly easy to actually move forward with that. How do we connect them? How do we bring in organizations like Reach for a Dream? It's a really important part of dealing with their spiritual suffering and what gives meaning to their lives as well. So when we've done all of those, what about that little child? How do we assess that little newborn baby, that 2-year-old? The 2-year-old that might be starting to ask questions, but can't really give you deep answers if you ask them where the meaning is. And that is observation. We have to become extra observant. We observe with our eyes, we observe with our ears, but we also observe with our heart. We can see how these children, that child who pulls back, that child who can't be cuddled, or that child who is absolutely connects to everything and everyone. How do we help that child? And so we've got to look at ways of helping when that child can't talk and doesn't really know what gives meaning except to get up in the morning and to play, or to have mommy and daddy with them, or to know that the nurse and the doctor love them. And those are all parts of providing spiritual care. How do we look at how we help them to connect to each other when they're in that busy ward? And part of it is having open wards where at least there's just glass screens between them. And many of the wards are the children on top of each other. How do we do something? It might be through music. It might be through getting little shakers that they can do together. Those are all parts of spiritual care. It mightn't sound like it. And also very aware of the time, and we've spoken about legacy, is how do we involve religious beliefs as well? Because when I first started studying, it was spirituality is one thing, religion is another. The two merge so tremendously. If your religious beliefs are important to you, you're going to express a lot of your spirituality through your religious beliefs. So to look at with those children, are there symbolic actions that you can do? Are there things like candle lighting? Are there things like bells and incense and smells that can be brought in to make them feel part of their spiritual religious community as well? And a lovely description, I think, of how we use spirituality and religion is that spirituality is the journey and religion is the vessel. It's the boat, it's the car, it's the aeroplane. It's that thing that is bound by some rules and guidance and special literature and that kind of thing. So then the connection to nature. Now, of course, nature is easy. If we can't take them outside, we can bring nature in, can't we? And we have a wonderful doctor on Patch, Dr. Jan du Plessis. He had a patient with cancer who said she'd always wanted to touch a snake. And we have a wonderful photograph of Jan that I think we really should share soon. He said he put his courage and in his fear into his pocket. And he's sitting there with this great big snake wound around his arm. And so while we don't expect you to go to that level, you can bring in the dog, you can bring in the cat, you can bring in the hamster. You can show them pictures, you can show them videos, and to use videos is wonderful. Things that they can connect to in that way. And then, of course, the transcendent. As they get older, they start to have a concept through their faith, through a feeling of something bigger than they are, transcendent. And I've always found that working with kids is that getting them to look at the stars. If they can't express this feeling of connectedness to transcendence, just take them out or look them through the window and let them look at the stars and the moon, because that gives them an idea of something that is greater than they are. And that connection we can do through religious rituals that have meaning to that child. And this is where, if you have a chaplain, and there's a tremendous role for a properly trained palliative care chaplain. Just because someone is a pastor, a priest, a minister, doesn't make them good at spiritual care. In fact, some of them are really, really bad in a palliative care situation. So we have to really be very careful who we allow to come in to do that spiritual care. Not the one who comes and says, you know, in the name of God, you will stand up and walk. That's not spiritual care. That's giving fear. That's making people feel guilty. So there are many things that we can do. Just as we're going past, tell them, you look pretty today. That's building on their self-esteem. You can say to them, why don't you draw a picture and I can take it to that little boy over there who can't get out of his bed. That's a connection to others. You can ask them, what is really special for you? What do you love doing? What is exciting for you to do? And how do we bring that? How do we allow them to do that? And it could be part of that legacy. If they want to have purpose and meaning, it's leaving something to someone else that Tracey spoke about as well. Tracey without an E. And so spiritual care is part of what we do. It's the way that we talk to someone, the way we listen to someone, the way we use that sixth sense to understand what is important to them, the way we help them feel in that busy ward where they're sitting in their cot, sitting in their bed, being pushed from pillar to post by strangers, is to make them feel that in all of this, there are people who care about them. And if we go back to the foundation of what spiritual care is, it's actually accepting that child and that family member exactly as they are and responding to their needs for meaning, for purpose, and for connectedness. And so that's a very tiny, tiny little bit. But if I can encourage you to find out about spiritual needs of children, I would say look for the poems of Matty Stepanek, who wrote about heart songs. And if anything expresses spiritual needs and spiritual suffering and connectedness, it is Matty, who died at the age of 13 and who left behind a profound legacy. Thanks, Sue.
Thanks so much, Joan. That really, as you say, was a very small bit of what spiritual care is. Joan and I and Tracey worked on the spiritual care course that's available on Patch Academy. In fact, the tools that you spoke about, Joan, are in the book as well, in the Bettercare book. But the spiritual and cultural care course on Patch Academy has got 5 ethical CPD points. So that's something, if you are really interested in that, we would encourage you to do that. The last question is for Melissa. And it's something that Melissa is passionate about, and I see it's come up in a question in the chat as well. And that's about, the question goes, Melissa, you spoke about the importance of self-care yesterday. You speak about it often, but how do we manage to care for ourselves when we are so busy caring for others, including our own family members? And I see in the chat, it was about how do we care for ourselves when we grieve the loss of one of our patients. So Melissa, over to you.
Thank you, Sue. And I'm so mindful of the time because we've all got so much to say in such a short time. So I'm going to try and keep it brief, but I think, as I said yesterday, when we really consider the heart, that's what we're needing to look after. And when I say that, it's about not protecting the heart. Remember yesterday I said we need to lean in, we need to feel that protects one's heart. So when I don't have my Footprints for Sam hat on, I'm actually a life coach and a palliative coach, and I'm passionate about debriefing and coaching professionals. I have a coaching approach to mindfulness, to resilience, and I know a lot of health professionals, especially the surgeons, say to me, "You're not going to make me do yoga, are you?" So this is not about yoga, but this is about, yes, as part of it. I do say, I am going to make you breathe. I am going to make you be mindful. And sometimes people go, "Oh, that's the fluffy stuff." But when Tracey was so passionately talking about grief and grieving, the one thing that's so important that she didn't have a chance to cover, but which is so key and part of self-care, is that you also need to allow yourself to grieve. Because remember, you are in a profession of giving in healthcare. You're giving of yourself, mind, body, and soul. And we always say it's such a simple symbol, really. If you think of a glass that's half full and you empty that out onto somebody else, and then it's empty. So how can we make sure that that is going to be full again so that you can keep giving? Because otherwise you're going to suffer, most probably from compassion fatigue, which is known as the cost of caring, or from burnout. A lot of people are starting to look at what we actually call compassion fatigue, but let's not worry about the terminology. Compassion fatigue is the cost of caring. And ironically, pediatric palliative professionals have the lowest rate of burnout and compassion fatigue because of the way they lean in, because of the way that they get to know their patients. And that is something, I guess, is quite surprising. So I want you to remember that when you think, "Oh, I don't really want to get too close." That's something that's really important. So remember that those walls have to be permeable. They have to be healthy boundaries. We can't just put walls around ourselves, because then you're on the surefire road to burnout. And then remember also that the work that one does in healthcare is also quite traumatic. And given the fact that you've got the trauma of the daily workload, seeing patient dying, seeing children dying, children shouldn't die, and yet it's a reality that all of us are dealing with, seeing parents grieving, seeing the horrific things that obviously sometimes clash with our values, our moral principles, all of this is burdensome, and trauma is somatic, it's in our body. So a very small part of that is actually psychological. So we need to work with our somatic, we need to work with our bodies, and we need to get it out. So whether you go for a run, a walk, do your yoga, whatever it is, whatever your hobby is, it can be cooking, it can be gardening, but you need to mindfully take that time for yourself. And also to say to your family when you get home, how is it that you're moving from space to space? Because often you move from the hospital, and when you get in your car and you get into bed at night, all the patients, not physically, but emotionally, are crowded up against you. So you need to learn, how am I going to create, we call it almost a pause break. How do you create that space between the emotions, the angst, the feeling, and your response and what you're doing with them? So we need to create space between that. And that's where mindfulness comes in. So being present in the moment, especially at a time of COVID where there's the loss, the grief, the pain, the turmoil, the uncertainty. There's a high level of anxiety. In truth, at the moment, there really is an emotional pandemic alongside COVID. And one has to realize that there's all sorts of fallout, because everybody was kind of on the train trying to get through 2020 and thought, "Oh, we're going to get into 2021 and it's going to be a little bit uncomfortable, but the worst is probably over." But realistically, many of us knew, especially those at the coalface, that there's still a long road ahead. And it's this uncertainty that's creating such emotional anxiety. And also there's a phenomenon now of moral fatigue. And that's really because we are surrounded by day-to-day decisions that one used to make on a normal basis. But now every single decision you make comes with a moral sort of implication alongside it. So for example, I'm now going to go to the shop, which was a simple decision in the past, but now when I come home, I might have been in contact with someone, I might have had a long conversation with someone unbeknown to me that they had COVID, and now I'm bringing it home. Worse still, for health professionals, you're dealing with dying patients, you're dealing with the day-to-day trauma. So you can imagine that compassion fatigue, that moral fatigue, moral injury. I don't know if many of you are familiar with that, where what you're seeing every day becomes traumatic and burdensome, in almost a psychological impact, because it's clashing with your values and your principles. So these are all things that you have to bear in mind that are happening every single day. So you have to pause. You have to take time for yourself. And all of the health professionals I debrief, I've done hundreds of coaching sessions and really debriefing on a weekly basis. And they all say, "But we don't have time." So I say to them, literally, how often are you washing your hands every day? Take that time to pause, mindfully feel the soap, feel the water, and use that time between patients to wash away what you've just seen and heard. And when I say that, you're not forgetting your patient, you're not forgetting the family, but what you are doing is just pausing, you breathing, you engaging your parasympathetic nervous system, almost like a parachute, and you slowing things down. You need to get off that hamster wheel. And I know it's easier said than done, but literally check your breathing. That's the easiest way to engage mindfulness, to stop, to ground. And I really can't emphasize it enough. So if anyone's interested in knowing more, you're welcome to drop me a mail, and we can expand on that. But again, Bettercare Book, the courses on the Patch SA Academy site, it's all there. And yeah, it's just putting it into practice. One lovely one I always give to nurses and doctors who finally might have that final cup of tea at 5 o'clock, or the meal that they were meant to have at 9 o'clock in the morning. Stop, taste the food, engage your senses, and just set your intention for the day. Today, I'm going to be kind to myself, not just to others. Today, I'm going to be compassionate to myself. Today, I'm going to give my wife a kiss when I get home, or my husband a kiss and an extra hug. Because remember, now is a time of complete disconnection. So we need to reconnect with our bodies, reconnect with those around us, and you have to do that mindfully. So thanks very much. Again, we could do lectures on each of these subjects. So I think we're going to have to come to an end, because we're literally at 3 and we haven't even looked at the Bettercare solution, Sue. So I think, Trace, are you still there?
Yeah.
Is she there? She vanished.
I'm here.
Okay, you're there. We can't see you. Wonderful. So just to kind of close off that session quickly, and Trace, how long are you going to need just to give a little bit of background to the Bettercare Book?
5 minutes. I can do it in 5 minutes.
Okay, great. So we're going to hold her to that. So I think to say, Sue, I'm sure you want to say thank you to the panel.
Absolutely. I would like to thank our expert panels. All of you spoke with such passion. And I think that those of you who have joined us over the 3 days, I hope that you feel that if you have an interest in children's palliative care, there is an enormous supportive network in South Africa. We are all here. We are all willing to help. We really want you to get on board, because children's palliative care is a right. So enormous thanks to Melissa, to Tracey Brand, to Tracy Rawlins, to Joan, and to Michelle and to Dr. Julia for their incredible just sharing of their knowledge and understanding today. Just an enormous thanks, and for everybody for being here.
Thank you, Sue. Tracy, with run through the Bettercare book and how one uses it and how we really get those study groups going. And then before everybody vanishes thereafter, and I'm sorry we're going to be running 5 minutes over our time, but I think we've been pretty prompt with all of our timekeeping, is I'm just going to put a little bit of a poll out there that will take a couple of minutes to answer. Everybody could just give us some feedback so that we can make sure that these sessions continue in a mindful and productive way, that we are giving you what you need and what you're interested in. Thanks so much, Trace.
Okay, so over the last 3 days, I say we've presented so much information to you. We've given you a lot to think about. And I think this quote by Margaret Fuller is, if you have knowledge, let others light their candles in it. And I'm hoping we've lit your candles, and I'm hoping you're going to go forward with this Bettercare book and encourage others with yourselves to do the book, and then to encourage others to participate in group activities if you so inclined, with facilitating and organizing self groups. So let's just look at the Bettercare. For those of you, all of you will be getting a book. I'm not sure how many of you received your books. I'm sure you've had a look. You know, this is what the book looks like, the front and the back. The Bettercare, there are many books in the Bettercare series. Professor Dave Woods is one of the founders of the Bettercare program and self-group facilitation. And he was the one who felt this was a really good way for persons working in institutions, in facilities, to actually learn very brief, simple knowledge way of gaining knowledge. So the book can be done online for those of you who haven't got the book. It is there and available, and it's free. You don't have to pay to do the course online, but you cannot download the book. That's just one thing to let you know. And then those of you, there's the printed book. I'm sure those of you who got the book have looked through it and will see that the methodology is a question and answer format. So a simple question with an explanation. And then there's the next question, which leads on to the previous information. And so you go through the book. So it can be done either as a self-study or as a multidisciplinary study group activity. And also it can be used as a reference guide. And I think it's just keep it on hand with you. You might be asked a question, you might want some information, and the answers will be there for you. So how we go about using the book, if you go to the back of the book, I don't know if any of you have had a look, there's a pre and post knowledge quiz for each chapter. So in order to do the chapters, you should initially go and do the first pre-course quiz, go through the chapter, read, go through the resources if they're available, and then once you've done that chapter, come back and do the post quiz knowledge quiz. And in that way, you're going to gain the information and see what you've gained from that, what you've learned from that, where your gaps are. And if there are gaps that you haven't understood, go back and maybe do more research or come on to our online academy. I know we keep pushing it, but it's true. We have based our courses on this book, but we've just gone into a lot more detail. Then once you've gone through those pre and post knowledge quizzes, the answers are actually at the back of the book. So you can mark yourself and see how you've done. And then again, in each chapter, there are appendixes that have been included. And all of these are resources that you can use in your workplace, and they are available for download on the Patch website. In order to facilitate a group, you would find a group facilitator who would organize your team meetings, your little group sessions. And the idea is to meet every once or twice, every 1 to 2 weeks or once a month, whatever time you can give up. And the facilitator would gather her group. She would encourage everybody to do the pre-knowledge test, send them through to her, or do that together as a group. Then each of you can go away and do the chapter on your own, read through it, look through it, gather information, and then you would come back, and this is where you would have your group session, and you would go through the chapter answering questions that you weren't able to answer, look at things that maybe came up that everybody's confused about or there's debate about. And then at the end of that session, you would then do the post-knowledge test, see where you are, and then at the same time, do the next chapter's pre-knowledge quiz before you go and read that chapter. So you can gauge yourself how well you're doing, what you know, and your gaps. And once you've worked through the book, there is an online final quiz that you can go and do. It's 100 questions. They're taken from the pre and post knowledge questions that you would answer. You get a certain time, you do it online. There is a fee involved to pay, but you would get a certificate of completion for that book. So it's nice to have that. And then I have at the moment, because of COVID and with Bettercare and Electronic Bookworks, who work together with us, they are negotiating CPD points if you complete the whole book and get your certificate of attendance or completion. If anybody wants to know about that, I will get back to you about that once we've got the final feedback from that. And then just to say, if anybody does want to put a group together, you've got the facilities for me to come online with you during a session. I'm really, really happy to engage with you as you work through chapters. And really, that is our book. And we really just hope that you use it, you put it to good use, you have it by your side. And the last thing I want to say is thank you, Melissa, for all those books. And I think everybody can give Melissa a big clap to say thank you. Your books are from Footprints to Sand, and it's her gift to you, and it's our gift to you with the knowledge that is inside there. Thank you, everybody.
Oh, thank you so much, Trace. And it's our pleasure as Footprints for Sam. Our passion is to share pediatric palliative care far and wide. And I think this beautiful book is a testimony to every person's heart. We all worked extremely hard on that book. It really was quite a slog, but it was worth it because it's absolutely beautiful. And I know that you're all going to love the Patch Academy course. We'll be looking to maybe put some kind of sponsorships together for those of you that can't afford to run the courses or pay for the courses on the Patch Academy. But Sue, correct me, I think they're all CPD accredited now. So it's a wonderful facility, and really great. It's a wonderful, wonderful way to, especially in this day and age when it's difficult to get into a classroom. I sometimes think online is far easier. You can fit it into your day. So without further ado, I don't want to make you all late for rounds. I'm just going to share the poll. If you wouldn't mind populating that for us quickly, we'll give you about 2 minutes to answer. It's just 6 very straightforward questions to help us going forward. And really, thank you. And we'd love to hear your comments. Drop us an email, say hi, keep in touch. Please like Footprints for Sam, Patch SA, Umduduzi, Pete's Pal, all the wonderful organizations on Facebook, on social media, so that you can see what we're all up to, and that way you can make sure that you don't miss out, because there's going to be lots of fun ahead. And we're just here to help you stay connected and to keep you informed on a very, very important subject. Thank you all. Don't vanish. The poll is coming up. Thank you so much. Bye.
Thank you. Bye.